Hi, this is Brian Kim. I want to share with you this case of a patient with a hypermature cataract, and you're going to see terminal chop, cross chop, mechanical fracturing techniques, scissoring chop. And at the end of the case, as I'm doing the cortical removal, you're going to see a small posterior capsule rupture. And so it's a little bit unusual as far as how it was formed, but then I'm going to show you how I managed that situation and then place an IOL within the capsular bag in a stable situation. So again, this is the patient. You can see this lens is quite dense. I'm using the cotton tip to steady the eye, and this is my corneal marker, which will help me to center and size the Rhexis. And this is my paracentesis incision, first on the right side and then the left side. You see I'm turning the eye so I can get a nice flat approach, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral lidocaine, and then some intracameral epinephrine, and then some intracameral air with trypan blue. And I like to paint the surface. I try not to be too aggressive with the dye. And this is some dispersive viscoelastic to coat the corneal endothelium, flatten the anterior capsule, as well as remove the bubble and the trypan blue. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then enter. I'm pushing some more viscoelastic. Then I go ahead and puncture with the forceps using the Rhexis marker on the forceps to just double check my size. Because this is a dense cataract, the corneal mark that I had is not as visible because of the poor red reflex. I'm going around carefully and circumferentially, trying to make sure I get a well-centered and sized Rhexis. Okay, burp some viscoelastic out. And this is the Capsulorhexis hydrodissection technique. I place the cannula under the Rhexis edge contra-incisionally, point the tip down, get a nice wave. Carefully decompress on the left side, and then hooking the peripheral lens on the right. You saw the lens spun quite easily there. Irrigating the surface of the eye, making sure my sleeve is appropriate. And I've talked to my staff about going to sculpt mode so I can create the groove for the terminal chop technique. Remove the surface epinuclear material. Turn the bevel down now, and then beginning the groove. And again, the beauty of this technique is I don't have to go too far peripheral. I do want to get deep enough to get most of the bulk of the dense nucleus out. But the key is you don't have to go far peripheral, because as you fracture terminally, it'll propagate the tear all the way posteriorly. I'm using the chopper just as a support here, as a counterforce, as I'm trying to groove and sculpt. When the lens is so dense, you end up pushing on the zonule, so I don't like to do that. And so now I'm initiating the terminal chop, fracturing from the equatorial plane, and the chop propagates all the way through and through here. Go ahead and switch the bevel down now, and then going to quadrant mode. You can see the lens is completely bisected, placing the chopper around that heminucleus, pulling it centrally toward the phaco tip, which is positioned deep in the bag, fracturing the lens in half with mechanical forces. Doing the same maneuver, fracturing that first quadrant in half, using a little vacuum to grab that first piece, which comes up, amputating the posterior adhesion with the scissor chop maneuver, crushing the lens into smaller pieces, and then emulsifying it. Going after this second piece, getting around it with the chopper, crushing the lens between the instruments, mobilizing the lens piece, positioning that fragment between the instruments, crushing it into smaller pieces, making sure there's no posterior adhesion, crushing it into smaller pieces more, and then emulsifying the lens pieces. To me, this is the most controlled and systematic way of fracturing the lens, separating the lens pieces from the rest of the lens piece, because that's really the challenge in these really dense lenses. They're all jigsaw puzzled together. And so you have to be able to separate the pieces completely. So I'm able to, again, get around the lens piece of this second quadrant, fracturing it, making sure the posterior adhesions are severed. So I'm able to mobilize that fragment and then crush it into smaller pieces and then emulsify the lens piece. Going after that remaining fragment of the second quadrant, separating first, grabbing it with some vacuum, lifting it up. Again, amputating any potential posterior adhesion with the scissor chop maneuver, crushing the lens piece into smaller and smaller pieces, using some vacuum to position the lens piece on the tip, crushing it between the instruments, and then emulsifying the lens pieces. Lifting that fragment up with the chopper and then grabbing it with some vacuum, crushing it. That's one of the central dense nuggets that I'm removing right there, and then emulsifying it. Very carefully rotating the second heminucleus in front of me, placing the chopper around the lens piece with the phaco tip deep in the bag, fracturing and bisecting that second heminucleus in half, separating the two pieces now, getting around that third quadrant with the chopper, crushing the lens between the instruments, crushing it again, grabbing that piece with some vacuum, crushing it between the instruments again, and then emulsifying the lens piece. I try not to emulsify the lens piece when the piece is much bigger than the phaco tip. By using mechanical forces to crush the pieces into small pieces about the size of the phaco tip, then I'm able to pulse it with a little bit of ultrasonic energy, but really in essence, I'm aspirating those pieces with high vacuum. Again, by doing it this way, very limited ultrasonic energy, very good control. You can see excellent chamber stability. I'm not going after pieces with the phaco tip. I'm always hooking lens pieces up out of the bag with a chopper, positioning the lens pieces between the instruments without having to utilize ultrasonic energy or vacuum. I believe this is very, very, very controlled, just like you see here on this last quadrant. I'm just positioning the instruments around the lens piece and then fracturing it. Again, not using any vacuum in order to do this, not burying or lollipopping the lens with ultrasonic energy. By doing it this way, I feel it's very, very controlled. Yes, it does take some time. Yes, I'm using a lot of fracturing maneuvers to crush the lens pieces into smaller pieces. But guess what? When I see these patients postoperatively, they have much clearer corneas postoperative day one. And even after the surgery, when they're leaving the operating room, oftentimes even these dense lenses, the patients are able to see a difference and an improvement in their vision. So again, those are evidence to me whenever I see that experience. And having done this way for thousands and thousands of cases, it just proves to me that this is really the best way to do cataract surgery, by carefully fracturing the lens pieces using mechanical forces and then emulsifying the lens piece with the phaco tip. Again, it's really more like a phaco-assisted technique, using primarily vacuum to aspirate the pieces out and primarily focusing on mechanical forces to crush the lens piece. Again, you don't need any extra instrumentation, no expensive equipment. You just use your chopper and your phaco tip. So you can see this last quadrant very carefully fractured into smaller pieces and making sure that my action is away from the posterior capsule during all the maneuvers here. You may say, why did you say you have a posterior capsule rupture? Well, you'll see. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. So far, everything looks just fine. Going ahead and removing the cortex, but I think I sense something's a little weird here. So you can see that's why I'm very ginger and careful about going after the cortex. So very carefully engaging the anterior cortex and trying to peel it off so I don't have to spend too much time here. And then now that I'm done, I'm going to sit here and look and say, wait a minute, I see something flapping around. Do you see the posterior capsule just to the right of the center? There was something that was flapping around, and it's right there. There's a horseshoe-shaped posterior capsule tear. I don't know how it happened, but now I'm going to be very careful in pushing some cohesive viscoelastic to fill the capsular bag before I come out with the INA handpiece. I went back and looked at the video, and I really don't see how and why there was a posterior capsule rupture. So I'm going to go ahead and sweep with the capsule sweep here, polishing underneath the Rhexis edge, 360 degrees. And sometimes you just don't know. Obviously, there must have been engagement of the posterior capsule. Not sure how it happened, but because my technique is so gentle, you can see that the tear did not propagate and I did not lose any pieces. And so I'm pretty confident the hyaloid face was not ruptured. So you can see now I'm placing my Rhexis forceps in here. I'm with the teeth closed. I'm just teasing the edge to create a little bit of a flap. And then I'm grabbing that edge of the flap and I'm able to create a round posterior Rhexis opening there. So I just create a little rounding of the tear so that it doesn't propagate or radialize. So again, filling the bag with some more viscoelastic. And this is a single piece acrylic lens. It's going to go into the capsular bag very carefully. And that's the beauty of this lens. A single piece acrylic lenses open up very slowly, so you have time to position the haptics into the bag. And you can see that tear was not peripheral at all. It's more like mid-peripheral. And there's complete coverage of that defect with the lens optic. And I have a well-centered and sized Rhexis as well. And so I'm not terribly concerned about vitreous here. When I go in with viscoelastic removal, I'm bringing the IOP way down because I don't want to have super high pressure as I'm removing the viscoelastic. And so this is in cortex setting, low IOP, removing the viscoelastic in the anterior chamber. And then I go under, turning off the vacuum, keeping the port away from the posterior capsule defect, removing the viscoelastic from underneath the lens, and then now in the anterior chamber. And then I'll hydrate my incision. So again, this is a patient who had a hypermature cataract. You saw terminal chop, cross chop, mechanical fracturing, scissoring chop, amputating the posterior adhesions very carefully and gently in a very controlled manner, fracturing the lens pieces into smaller and smaller pieces until they're bite size, and then removing the lens pieces. You can see the CDE is just around 10.02. I normally go single digits, but a little bit over here. But again, limited ultrasonic energy. This really does translate to clear corneas postoperative day one. And you can see here perfectly well-centered and sized Rhexis, 360 degrees of IOL overlap. And you can see there's that round posterior capsule defect right there. This is essentially a routine case with a well-centered lens, again using mechanical fracturing forces to disassemble and break down this extremely dense hypermature cataract. And again, postoperatively, the patient did very well, was seeing well even post-op day 1. And this is, to me, the best way and most efficient way to break down a lens with minimal ultrasonic energy and vacuum, minimal trauma to the corneal endothelium. And you can see the CDE is minimal. And again, this case took a little bit longer because I had to do those extra maneuvers. But to me, this is the gentlest way and the best way to do cataract surgery. So I hope this was helpful to you, and I thank you for your attention.